This presentation will cover various female reproductive disorders such as menstrual issues, infections of the lower genital tract, benign tumors of the female reproductive tract, pelvic organ prolapse, and cancers of female reproductive tract. You will want to refresh yourselves on the female reproductive anatomy as well as a normal menstrual cycle. Dysmenorrhea is painful or difficult menses. There are two types. There's primary or functional dysmenorrhea, and this is what there's a normal menstrual cycle and no pelvic pathology. There is an increased prostaglandin and leukotriene production in the uterus. And then there's secondary dysmenorrhea, and this is associated with pelvic pathology. Clinical manifestations include abdominal cramping, headache, nausea, vomiting, diarrhea, and fatigue. Severity of symptoms tend to be worse in those with early menarche, longer menses, heavier menses, or those who smoke. Symptoms are related to the onset of menses. Symptoms typically last 24 to 48 hours and occurs cyclically. Treatment for dysmenorrhea include NSAIDs, combined contraception, this includes estrogen and progesterone, herbal preparations and omega-3 supplementation, transcutaneous nerve stimulation, heat therapy, exercise, and acupuncture. And if these treatments are not effective after 6 months, a laparoscopy can be performed to rule out endometriosis. Pelvic inflammatory disease, or PID, is an acute infection that originates from the vagina or cervix and ascends to the upper genital tract, infecting the uterus, fallopian tubes, and ovaries. Risk factors include unprotected sexual intercourse, multiple sexual partners, STIs such as chlamydia or gonorrhea, sexual intercourse at 25 years of age or younger, oral contraception use, and previous history of PID. Clinical manifestations of PID include lower abdominal pain, uterine tenderness, adnexal tenderness, which is pain in the ovaries or fallopian tubes during examination, cervical motion tenderness, and abnormal purulent vaginal discharge. Complications of PID include septic shock, peritonitis, embolism, chronic pelvic pain, infertility, ectopic pregnancy, tubo-ovarian abscess, which is the inflammation mass involving fallopian tubes, ovaries, and nearby organs. Diagnosis is made through clinical observation of abdominal pain in combination with other clinical manifestations. Additional criteria include oral temperature greater than 100.9 degrees Fahrenheit, vaginal fluid neutrophils on microscope, elevated CRP or ESR, laboratory confirmed diagnoses of chlamydia or gonorrhea. Additional tests can be made such as transvaginal ultrasound, MRI, endometrial biopsy, and laparoscopy. Treatment is done on an inpatient or outpatient basis depending on severity. Treatment includes broad-spectrum antibiotics, abstaining from intercourse for 3 weeks, avoiding douching, tub baths, or tampon use, having the partner test if the cause of PID was a STI, educating on safe sex practices, and reporting worsening pain or vaginal discharge. Endometriosis is when endometrial tissue grows outside the uterine cavity or endometrium, resulting in pain. Clinical manifestations of endometriosis include dysmenorrhea, excessive bleeding during menses, pain during intercourse, or infertility. Diagnosis is made by obtaining history of symptoms, a laparoscopy with biopsy of suspicious lesions. Medical treatment of endometriosis includes oral contraceptives, NSAIDs, gonadotropin-releasing hormone agonists. Surgical treatment includes surgical removal of all endometrial tissue through excision, cauterization, or laser vaporization. Extreme cases may result in hysterectomy with or without oophorectomy. Leiomyomas or uterine fibroids are the most common solid benign tumors of the female pelvis. It's the leading cause of a hysterectomy. Etiology is unknown, and it's defined by its location. You'll see the different types of fibroids in the image. Clients with leiomyomas are often asymptomatic. They may have a heavy menses related to an increase in uterine and endometrial size. They may have prolonged irregular bleeding, often resulting in anemia. Blood transfusion may be required. They could have pelvic pressure or painful intercourse. The client should be instructed to count pads to evaluate the amount of vaginal bleeding. Diagnosis is made based on symptoms, pelvic mass palpated on pelvic examination, transabdominal or transvaginal ultrasound can detect the fibroids, and lastly, MRI. Treatment of leiomyomas include combined contraception pills to control bleeding and dysmenorrhea, gonadotropin agonists to induce a menopausal state and reduce fibroids and bleeding. This can result in bone loss and menopausal symptoms and is often used prior to surgery. The client may undergo a myomectomy, which is the removal of visible and accessible fibroids. The uterus remains intact. They might repair it. The client could undergo a hysterectomy, which is the surgical removal of the uterus. This results in infertility. And the client may undergo a uterine artery embolization. This is where the uterine arteries are accessed through femoral arteries. Embolizing material is introduced, which cuts off the blood supply to the fibroids. Pelvic organ prolapse is weakening of the muscle. It often happens to women who have had children, although not always. Uterine prolapse is the downward displacement of the uterus into the vaginal canal. Cystocele is a weakened support between the vagina and the bladder. Rectocele is a weakening support between the vagina and the rectum. Treatment for pelvic organ prolapse is Kegel exercises, a bowel regimen to prevent constipation, and surgical repair. Cervical cancer is the 13th most common cancer in women in the United States. It is a slow developing disease that begins with early cervical dysplasia, which develops into malignancy if it goes untreated. Risk factors include HPV strains 16 and 18, herpes simplex virus type 2, smoking, douching, poor nutrition, oral contraception use. To reduce your risk of developing cervical cancer, you should undergo routine pap smears and have the HPV vaccines. With cervical dysplasia, there aren't often recognizable symptoms. When it develops into malignancy, the client may have vaginal bleeding, postcoital bleeding, abnormal vaginal discharge. Late symptoms could be pain, weight loss, anemia, and cachexia. A pap smear and HPV testing is initially performed, and if there are abnormal cells detected, the provider will perform a colposcopy and cervical biopsy. A colposcope is inserted through a speculum into the vagina. The cervix is swabbed with a solution, allowing abnormal tissue to be identified and sampled for biopsy. Remember, biopsy is needed for definitive diagnosis. A MRI or PET scan may also be used. Treatment for cervical cancer includes laser treatments or ablation, cryotherapy where they freeze the malignant cells, surgery such as hysterectomy, radical hysterectomy with lymph node dissection or pelvic extenuation, external or internal radiation, and chemotherapy. Endometrial or uterine cancer is the most common gynecological cancer in the United States. Risk factors include unopposed estrogen exposure. This is where there's estrogen therapy in the absence of progesterone replacement, obesity, cirrhosis, estrogen-producing tumors, anovulation. This is where the ovaries do not release an egg during a menstrual cycle. Increasing age, null gravida. This is for women who have never been pregnant. Early menarche, late menopause, smoking, and diabetes mellitus. To reduce your risk of developing endometrial cancer is pregnancy, the use of oral contraceptives, use of IUDs containing progesterone, and physical exercise. Postmenopausal women may develop vaginal bleeding, and premenopausal women may have irregular or heavy bleeding. Late symptoms of endometrial cancer include dysuria, difficult or painful intercourse, or pelvic pain. There is no routine screening for endometrial cancer. Diagnosis is made through biopsy, pelvic ultrasound, or surgical DNC, which is the scraping the lining of the uterus for tissue sampling. Treatment of endometrial cancer includes total hysterectomy with bilateral salpingo-oophorectomy with lymph node biopsies, radiation, and chemotherapy. Ovarian cancer is often detected in late stages. It causes the most deaths of all gynecological malignancies. Risk factors include a family history, BRCA1 or BRCA2 gene mutation, nulla gravida, increasing age, high-fat diet, early menarche or late menopause, use of hormone replacement therapy, and use of infertility drugs. Risk reduction includes breastfeeding, multiple pregnancies, oral contraception use, and early age at first birth. Symptoms might start out as vague or nonspecific. The client may have bloating, pelvic or abdominal pain, gets full quickly, has urinary urgency or frequency. Late stages often present with ascites, unexplained weight loss or gain due to the ascites, and menstrual changes. There are no routine screenings for ovarian cancer. Diagnosis is made through drawing a CA-125, which is a tumor marker, a CT scan or ultrasound. Biopsy is not recommended for this cancer to avoid spreading the disease. Definitive diagnosis is made through surgical removal of the mass. Treatment includes surgical staging and debulking of the tumor. The client will undergo a total hysterectomy with bilateral salpingo-oophorectomy with lymph node biopsies and chemotherapy. This slide includes the different types of surgery that have been discussed in this voiceover. Hysterectomy is the surgical removal of the uterus. It may be done laparoscopically, abdominally, or vaginally. A salpingectomy is the surgical removal of the fallopian tubes. This may be done unilaterally or bilaterally. Oophorectomy is the surgical removal of the ovaries. This also may be unilateral or bilateral. Myomectomy is the surgical removal of fibroids. It leaves the uterus in place. Pelvic extenuation is the radical hysterectomy, total vaginectomy, removal of bladder with diversion of urinary system and resection of colon and rectum with colostomy.